I'm Donna Prasad. I'm a pediatrician, and when we started that program, I was the chief of pediatrics for the Parkland Community Oriented Primary Care Clinics.
And I'm Dr. Barry Lachman. I'm also a pediatrician, and I'm the medical director for Parkland Community Health Plan. And a lot of this started when I realized we had a lot of asthmatics in the health plan, and we weren't doing very well at keeping their disease under control.
And I'm Yuron Pengedze. I'm a pediatrician as well. And all this started when I was completing my fellowship in health services research and academic general pediatrics at UT Southwestern.
So I think to set the stage, what started is the Affordable Care Act 1115 waiver projects, and there were $1.2 billion allocated to this area of Texas, of which Parkland was going to be allocated about $570 million split amongst the different projects. And we were alerted in the initial menu of projects we could pick from the state that pediatric asthma was one of them. So we thought this was a big opportunity. We were going to get millions of dollars to improve the care of children in Dallas with asthma.
We started doing home visits, and we started managing kids down to birth who we used as having asthma. But then the Parkland clinics got patient-centered medical home classification, and disease management kind of began to go out of vogue. And in looking at it, we then said, well, gee, we kind of neglected the primary care providers. And Parkland clinics were our biggest provider. And along the way, we developed a way of managing the data, and we had case managers at the health plan, and we had health coaches that involved. And now we had care coordinators in the primary care home, and Dr. Prasad and I decided that we maybe had too many cooks, and we needed to coordinate people. And one of the aha moments was that the COPCs had decided, the community clinics had decided that for the one intervention we had, the one thing they wanted to know was whether we had a case manager at, involved in their care at the HMO. And I went, is that all you really want? And yeah, we're going to start small. I said, okay, that makes sense. And so we're sitting in the first meeting, and everybody was absolutely delighted. They knew there was a case manager. And I said, well, what's his or her name, and what are they working on? And we suddenly realized how much bigger this issue of care coordination was. Then the Parkland Center for Clinical Innovation came along, and we got the opportunity to develop a predictive model. And that really led to us really beginning to think about what's a comprehensive model for asthma care, what information do we need, and how do we get it to people on a timely basis that the data that we have is actionable.
That's true, and that's when I came into play. As I was finishing up my fellowship, the founder of PCCI, the Parkland Center for Clinical Innovation, Ruben called me and said, hey, I have a few pediatric projects going on here, and I need someone with a background of research that would get involved in these conversations. So that's how I got on the phone the first time with Dr. Prasad, Dr. Lachman, and all of us started talking about, the NAPE project, and we started discussing, the daunting HEDIS metrics. Those are very retrospective metrics. What do you do with it once, things have gone and happened? And we started thinking, hey, can we get ahead of that and actually predict the risk for bad asthma outcomes, like patient ending up in the emergency room or hospitalized, and then maybe figure out among those risk factors if there are risk among those high-risk patients, if there are any risk factors that are potentially modifiable that we can put in the hands of the providers in a timely manner. And back then, when I wrote my K-23 during the fellowship, I was really eager to look for a partner, and I couldn't find one. So it was just amazing to get here and find out that this Parkland Community Health Clinics with Dr. Prasad actually had data that were available, and they were ready to collaborate with us as frontline providers, and then the Parkland Community Health Plan with Dr. Lachman had a set of patients with longitudinal data that we could use to do that prediction. So we all sprang into action and started working. And again, the goal was to try to come up with something that was practical, that was very much actionable at the point of care, and start small and then expand from there.
I think another, when we began to look at the world of data, and the thing that Donna brought up about looking at some of the differences between the data that's available in an electronic health record and the data that's available in the claims system. And Bob Kowalski, who's our director of operations, and I came up with a way of thinking about this and describing it. And so we pointed out that in EHR, the data is a mile deep and an inch wide, because you have no idea of anything that goes on outside the purview of your electronic health record. So if it happens at another hospital, it might as well have happened in another universe. On the other hand, claims data is an inch deep and a mile wide, because you know everything that happened at every hospital, but you don't know if the patient has diabetes, you don't know what the hemoglobin A1C is. You only know that they have diabetes and that they had a hemoglobin A1C. Same thing for high blood pressure. You know they've got the diagnosis, but you don't know, is it in control or out of control? And so when you combine those, you come up with an ocean. We call it big data because it's big. I liken it more to the Pacific Ocean. And the problem for somebody actually seeing that patient is they're looking for the pearl in the middle of the ocean.
Absolutely. And one of the things that we're looking at also was to make sure that, we get some early wins. It is very important to keep people engaged and keep people activated, to look at, hey, are we even seeing anything here? Is there anything exciting going on here? So looking at the data, we found that there was quite a few areas of gaps in care that could have been closed, and that would have been a blind spot if we didn't do that in-depth analysis. So we designed our interventions around filling those gaps, and then within a few months, it wasn't even 6 months, we had a first analysis, and it was truly just to look at, hey, is there any trend going on here? And we were pleasantly surprised to see that there was some positive trends in provider prescription behavior change at the COPCs that was changing based on the data we're providing, giving these providers, and the information we had with them, and interaction and motivation that came from their leadership under Donna's leadership over there. And I think that was a big motivator for the program to keep going forward.
One thing I'm thinking about is, what is the recipe of who it takes to pull off something? There's a recipe of who, and then there's the mixing of the pot. And, here we had a care system, and someone in the care system willing to convert and try something different. And then we have the health plan that has the data, but doesn't have the window into the health system, and then the data scientist researcher that can do the in-depth work that is translatable, that the other two can understand. And that's the recipe of who's doing the work, being at the table, and then who's got skin in the game, the payer, and then the innovator, from the research and development. And we didn't think about it at that time, but it's the ideal type of recipe that most are aspiring to set up structurally now, and the three of us came together and did it then.